Welcome to another episode of season 2 of Dr. G at the Heart of Healthcare. Today, we are going to talk about occupational therapy, OT. I've been wanting to do this for a long time. Our expert today is Geraldine Joan Baptiste. Should I try to have a French accent? She is a manager of Lone Oak Garden RCFE and an LVN and COTA. When I saw those credentials, I was like, what does that mean? And she educated me. So welcome to the show.
Thank you. Thank you, Dr. G. I thank you so much for allowing me to be on your podcast today. COTA stands for Certified Occupational Therapy Assistant.
Yeah,
Uh,
yeah.
yeah.
I'm glad you taught us. Let me just tell them how we met. I actually went to the boarding care. That's what an RCFE is. Sorry, everyone. You guys know I defined that before, but it's such a homey environment. It's a family business here in San Diego, Vista, California, and it just felt so warm. And your cousin, did such a good job getting me all the information I need for the patient I was visiting. And so you guys are doing great work there.
Oh, yes. Thank you. Uh, Lone Oak Gardens, we started back in 2021, and that's our goal. Our goal is to provide a warm and loving home to our elderlies out there who are looking for a home. Because we know usually they're coming from their own home or being with their loved one or their children per se, and they're coming to my home. So I would like to continue that environment of family orientation, of being family oriented and warm and loving. So that's the goal for Lone Oak Gardens. Um, yeah.
I don't know when my dog is barking, but that's fine. So I don't know if you want to share a brief bio about yourself. I know you work with your husband, you have 2 sons. Just anything about yourself before we jump into the education for today.
Okay. I started as a LVN in 2008. I went to school to be an LVN, practiced that for a bit, and then I became interested in what else is out there that I can help others. Um, that's when I learned about occupational therapy. Um, I went to school. It was a 2-year program at Grossmont. I went to school to be in occupational therapy. And right away, within the first semester, I knew this was something that, I, I love this. This is completely something that will help others. Like I really like to, in addition to my LVN. So I did practice OT for a long time and kind of had LVN to the side for a little while. But I still find the fulfillment of helping others, being an OT and an LVN as well. Um, in 2021, I mentioned this a little while ago, we started Lone Oak Garden, my husband and I. He's also in the medical field. So, and then we both have the passion for helping others. And him and I have been caring, per se, for our families from a very young age. So we knew our mission and our passion on this earth is to take care of others, specifically our elderly population, because we do see there's a huge need for them. So that has been lots of learning, building Lone Oak Gardens and learning the new ways too of taking care of them, while we're also implementing the skills that we have, the OT and the nursing component, and our education that plays a great role in our facility as well. Um, Yes,
Mhm.
we do have two boys. They're young, so they keep us very busy with school and practice, and keeps us young too, because we go out there and run and be a family and have fun.
You're
So
juggling.
at
You are
this,
juggling it all.
yes, so at this point in life, we're just managing everything, the kids, the family, the business, and enjoying life too while we're at it.
Nice, nice.
Yeah.
Well, thank you. Thank you for sharing that. So, while we were preparing for this episode, Geraldine kind of helped me understand OT better. As physicians, we often write home health orders, and in the hospital and all this stuff, but never really necessarily know everything that it entails. And so we're going to get into it once we share this quick story, because she gave me an analogy with the story. And so it was a great way to understand specifically about occupational therapy. So there was a story about a lady named Sue who this is a common story. It's often sad, and it just kind of triggers a crisis in a family. So let's just, go with it. This lady, Sue, she fell while reaching for a coffee mug in her own home, and she broke her hip. And she ends up in the hospital. She gets the surgery, gets it repaired, and then occupational therapy is there. PTOT gets assigned to her. So we'll just go with that. So I have a few questions. Like, I want to know, like, what is OT, and when is it necessary? How is it different from PT? And just all that stuff, like OT in the late stages of life. So that's what this conversation is going to be about today. So I hope everyone's taking notes, because Geraldine has so much to share with us. So tell us how you step into the situation, when someone has a crisis like that in the late stages of life.
In the late stages of life, it all started with assessment. So we start with an assessment to see what are their abilities, and where we can meet them as far as getting them back on their feet and their independence, even with the natural decline of a late stage. So we'll go back. What is OT? Um, OT is it's a healthcare profession that helps and treat all ages, residents with all ages, patients with all ages, to regain their independence and improve their abilities to do their daily activities. We take an approach of a holistic approach. So we treat our clients from the physical aspect, the cognitive aspects, the cognitive problems that arouse, emotional challenges, and we do all these through meaningful activities that this individual was already doing on a day-to-day basis. Yeah. So when it comes to the late stage in life, we focus on maintaining quality of life. And that goes hand in hand with um, doing meaningful activities again, and engaging those individuals with things that they love doing, whether it's planting or singing karaoke or writing. We are there to help them gain their independence through um, through their declining, as they're declining with age. Yeah. So in the different type of people who will benefit from OT could be, again, someone who had a surgery, the example you're giving, surgery, post-surgery. We work with children who had developmental delays or disabilities, physical disabilities. Even in some, which is outside of even in the drugs and rehabilitation arena, we are there as well to help cope and finding different sanitary lifestyles that would help those individuals cope. So we're in all aspects of life.
Wow. And so that's important info. Like I can recall rotating in an ALS clinic where I saw the occupational therapist there to help. So what's the difference between occupational therapy and physical therapy? Because I think people are familiar with that. We're talking about regular people, not healthcare folks. What is the difference?
The difference is that physical therapy will help a patient get stronger, by doing strengthening activities. They'll get stronger to get from point A to point B. So they'll get the strength that they need to get up and walk. Okay, and walk and meet that occupational therapy. Is going to walk to do this gardening activity. We're going to walk to go to the bathroom. We're going to put a function in there that and work on something that's going to be meaningful to that person, a functional activity. So that's the difference. We will engage that person in an activity versus the strength. Okay, so it's like more of the fine tuning of the skill of the person. That's the difference.
Okay. So sometimes people, when they come on hospice care, everyone knows I do hospice care. The family wants their person to get some physical therapy, and it's fine because we are, responsible for it in the conditions of participation, and we'll do the PT. And sometimes it's just to help them be able to, use the bedside commode or um, move around in the bed or teach them some things. With that, how does that connect? Because again, I'm
Mhm,
trying to understand how you all
mhm,
work together. Would it be helping them feed themselves to continue to do that?
mhm. So in that stage, yes, of feeding would be a skill that OT will help an individual at the end stage. If someone has difficulty to grasp in the spoon in order to eat, then we'll provide and educate on a built handle in order to hold that spoon and help you gain your independence to eat by yourself. That way, you have more control over your pace of how you're eating. There's different adaptive equipments or different adaptive like wares as far as eating bowls, or they have plates that will that's like a suction cup at the bottom where it could stay. For example, if someone is trying to eat but then they're causing a lot of spills, so that aspect alone of just eating or things like that we can work on. Positioning, if you're eating, you're sitting up at a 90-degree angle to help the food go down easier. Um, the seating itself, we can work on the seating. Is this an appropriate seating for this person when it comes to eating? So just the eating scale, the eating portion is, we can touch on so many things. The toileting, we work on transfers, doing the transfers correctly, the proper hand placement, and those are little things that that's not necessarily caught by the family members' eyes or even caregivers, to know that there's a certain way that you have to angle your feet, angle the wheelchair to make it easier to go to the wheelchair or to conserve as much energy in the body mechanics. So yes, hospice will provide the bedside commode, but learning how to use it properly also is a different is where we come in.
That's so
And say,
good.
mhm. Yeah, that's where we come in. The fine tunings of life is what we do.
Wow. So you were sharing earlier that you will assess a home for safety too. Tell us about
Mhm.
that.
Yes. So we assess the variety of things we assess is rugs and carpets. If an individual is using walker, the rug will cause a fall because the edges can fold at times. And there you go. The lighting, it could be the light, there's not enough lighting for that individual to see. There could be too many commonly used things that are overhead where you're trying to reach and lean, wherein we'll teach you, okay, we need to bring things to a level where you can reach. Um, let's see, for the home, having enough clearance when it comes to walkways or areas that are appropriate to build ramps to make it easier to access your home. So all these are like safety areas in the bathroom. Um, the proper way when you get out of the shower to prevent a fall. You want to put a towel on the floor. You want to step on the towel. You don't want to step directly on the floor. It's probably slippery. You want to step on a towel and still, while you're still getting dry. So those grab bars also are very, very, very good tools to have in the showers, in the bathroom, all around the home, to use them to help them to pull themselves up. So all these things we see when we come to a home, we see. And it's interesting because I remember on my first semester of school, my teacher keeps saying, "Oh, you're going to have your OT glasses. You're going to have your OT glasses." And it's so true. Not
Really?
everyone sees these little details. Yeah.
Okay, wow. So, let me remind the audience of the activities of daily living. I should have a pop quiz for them, but I summarize it to everything one needs to get to the kitchen table once they wake up in the morning. So, what do you have to do? You have to get out of bed, walk to the bathroom. That's transferring, right?
Yeah.
Toilet, take a shower, put your clothes on, and then feed yourself. I'm missing one. Which one did I miss? I always miss one. The six. I probably skipped over it. But oh yeah, transferring and ambulating. I mix those
Uh-huh.
up. But so those are the activities of daily living that are just the basic things that we're working on, and that people want to keep. And so, like Geraldine shared with me, she said the PT will help you get strong, but the OT is waiting for you when you get there to do meaningful activities. So, tell us more about those meaningful activities: gardening, knitting,
Mhm.
ADLs, and
ADLs, activity of daily living. Um, it's everything that you are already doing. We can work the bases as on the bed. If an individual is having a hard time just getting off the bed, we can work on bed mobility, which is turning, having the ability to turn right and left is so huge and creates so much more independence for that person, and motivation too, to roll, get out of bed, get up, and with that comes more independence. Um, Another activity of daily living is transferring. We're always moving. It's a bit different at that stage of life because we're transferring to a wheelchair, or we're using a device. Um, Another activity of daily living are those that you mentioned, like the self-care. But the fun ones are the gardening, where we work on the different tools that would work personally for you, or your own adaptive tool to do that activity that you enjoy doing, which is gardening or knitting. There's a lot of creative writing. Oh, legacy work, which is what we mentioned a little while ago. Towards the end of life or the late stage of life, we work on legacy work, which is where we work on writing. It could be writing stories to a loved one, or getting some things off your chest that you've always wanted to. Creating scrapbook, creating memory book to leave for your family, or even planning those final arrangements. OT can also be all part of that. And that at that point of life, if it is meaningful to that person to get those arrangements done, then it is their meaningful activity at the moment, because we meet them at different stages of their lives.
Wow, that's amazing. Like, this has been so eye-opening to learn all this. And for our lady Sue, looks like you'll get her when she's out of the OR and get her back to her home and everything all safe, right?
Oh yes. Oh, oh yes. Um, that's why we go out home and assess that we do have a safe situation and no more broken hips.
Yeah, no more broken hips. And I want to really, be sensitive though. Oftentimes, if an individual has a lot of other comorbidities, they don't recover, or some people are not candidates for surgery, and they're medically managed when they find themselves in that situation with a broken hip. And so, the family has to make a lot of decisions. How could you help us understand, some of the listeners, when you have to make that determination that someone's not progressing? How do you come to that, or what are some of the options they have in that situation?
Mhm. When someone is not progressing, so we do reassessment every 3 months or every 6 months. It depends on the facility, and we continue to get them to their maximum potential. And if they're not progressing at that point, we can find out like which like whether or not to continue, really, which intervention would be more appropriate for them at this point. Yeah, if they're not progressing, then we definitely there is another, let's say, area in the rehab. It's we do have like rehab assistant, or we have aides in the rehab that continues with not ADLs per se, but they continue the walking. Um, Once the term comes to me, I'll let you know. But they continue seeing the resident. If they're not appropriate for OT, then they can continue to see our aide, where they're not doing a lot of the skill work, but they're just continuing to maintain the function that this individual had built from OT. So we do have that option too. And from there on, there's still be physical and moving instead of not doing anything at all.
Hmm.
Yeah.
Yeah, I recently had someone on the podcast, caregiver. She's been taking care of her mother for 10 years, and she was just reflecting that she didn't realize she could ask for certain things. And so, her encouragement to healthcare professionals was just for us to have proactive communication with families. So, the last question I have is, when when should someone ask their primary care doctor for occupational therapy assessment? Like, if they're wanting to be proactive, they're not in the crisis situation of a fall, but they're, I don't know,
Hmm.
maybe they're slowing down. When
Hmm.
would
Yeah,
they ask? What would it be?
I'd say as soon as the caregiver or loved one starts to see that they're getting weaker, or mom is not getting up the same way, you start to see the subtle change then I think this is the time you should ask your doctor, okay, can we have an evaluation? Then the OT will come and see whether or not they're appropriate for the services. But I would say as soon as you see a decline or any changes that mainly it comes in physical changes, but also the cognitive changes too. If they start to be forgetful, or not being safe, or cooking and forgetting that the fire is on. So when you start to see little changes like that, I would say, yeah, give the doctor a call and explain to them what's going on and let them know maybe an OT eval might be appropriate at this time.
That's good, and that makes me think about, a recent situation where someone said, their parent hid that from them, those type of unsafe situations. And so,
Hmm.
we want to respect the autonomy of the seniors, but sometimes their adult children don't find out until they're in a crisis. And so, thank you for giving us those little tidbits so people can kind of pay attention,
Yes, yes,
so
yes. Yes.
they
Oh, and I remember now, our extensions and rehab who helps with continuing, I wouldn't say OT, but continuing to maintain independence is RNA. We call them RNA, rehab, restorative nurses aid. That's what I couldn't remember it a little while ago.
we have so many mnemonics in healthcare. I'm surprised we remember any of them, but
Mhm.
thank you. Thank you so much for teaching us about this. I appreciate your work and your expertise and the home that you provide in the community. Lone Oak Garden
Got it.
RCFE. And just thank you for everything that you do in the community.
Thank you. Thank you again for having me on your podcast today.
Happy to have you. All right. Peace,
Bye
everyone.
bye. Bye.